This is NNI Bites Big Learnings, a podcast where fellow healthcare professionals converse about the latest on nutrition science. We are joined by the chairs and speakers of NNI and WNSC Workshop 102 as they share practical insights on the impact of proper nutrition that contribute in the optimal growth of children.
Hello and welcome to the Nestlé Institute podcast NNI Bites Big Learnings with the series from the Nestlé Nutrition Institute Workshop 102, Growing Strong, Harnessing the Power of Nutrition for Child Health. I'm your host today, Bertolt Koletzko. I'm a professor of pediatrics at the LMU University of Munich, and I'm very pleased to be joined by Godfrey now, who is a professor of epidemiology and human development and works at the Life Course Epidemiology Center at the University of Southampton. He's also the co-chair of the UK Preconception Partnership. Hello, Keith.
Hello.
So your topic here at the workshop focuses around pregnancy and preconception. I guess much attention was raised many years ago around the importance of this period of life, and David Barker published the close relationship between low birth weight and an increased risk of later cardiovascular disease and other disorders like diabetes. Many years later, we are still fascinated by these observations, but the question has also been raised in other studies whether it is the growth of the fetus alone or whether it is the combination of fetal growth and adverse events after birth. So the combination of low fetal growth and rapid growth after birth, for example, in the Finnish birth cohort. How would you interpret the evidence that we have today?
I think the first thing to say is that fetal growth is in many ways a proxy for some of the driving influences and that have lasting consequences. So a number of the driving influences are associated with alterations in fetal growth, but not all of them. So some of the fetal adaptations and changes can be much more subtle and not manifest in overt changes in fetal growth. And another part of this is that for some influences, it doesn't require a mismatched later childhood environment, whereas for others, the expression of the fetal programming, as it's called, influences, is profoundly influenced by a mismatch between an adverse prenatal environment and an obesogenic later childhood environment.
Great. So fetal growth is important, and we have some indications that one predictor of fetal growth is maternal body size. Why is that, and how is that relation mediated?
So it's a great question and still incompletely understood. One of the main drivers of fetal growth is the blood flow to the uterus and thereby to the mother's side of the placenta. And in mothers with a smaller body size, that blood flow is lower. But it would be overly simplistic to say it was wholly down to that. There are a number of other influences, some of them genetic, some of them environmental, which underlie that association between the mother's body size and the growth of her fetus. The match between the mother's body size and the growth of her fetus is something that has been entrained through our evolutionary past. Because if there isn't such a match, the head of the fetus gets stuck in the mother's pelvis during delivery, and that leads to maternal death, certainly in our evolutionary past before caesarean sections. And so it has been developed out of the program, so to speak.
So you've indicated the important mediating role of placental blood flow regulation. You've also pointed to the importance of fetal blood flow changes, bypassing the liver with the ductus venosus shunt. How does that work?
So the ductus venosus shunt was first described in the diving seal, and it protects the unborn seal pup from hypoxia while the mother is underwater. And the ductus venosus is a bypass channel which diverts highly oxygenated blood coming directly from the placenta away from the liver and into the main circulation, and principally to the brain. And what we've been interested in doing is measuring that in healthy human fetuses. And it's known that this bypass channel exists in human fetuses and in other mammalian species. And what's surprising is the amount of variation in the shunt away from the liver. So in apparently healthy fetuses, some of them were shunting 10% and some shunting 50% away from the liver. And a halving in the reduction of the blood flow to the liver is a major change. And we know in sheep that if you block off the bypass channel or dilate it up surgically, you don't just have effects on the growth of the liver, but you have changes in all the growth factors that are produced by the liver, and consequent effects, not just short-term, but long-term.
Fascinating, isn't it? So we have more to learn here. From a clinical point of view, everyone knows that both low birth weight and high birth weight of the newborn are associated with adverse outcomes. So clearly fetal growth is important for long-term health. The question then from a clinical point of view is, what are modifiable factors during pregnancy and maybe even before pregnancy that could attenuate risk of altered birth weight?
So it's another great question, and it's one where the answers are work in progress. What's been actually quite disappointing is the benefits of interventions during pregnancy. So particularly in relation to high birth weight, and that's associated with diabetes during pregnancy, gestational diabetes. There were high hopes that behavioral and dietary interventions might have really profound benefits. And although the dietary management of gestational diabetes does have benefits, it doesn't have quite the long-term benefits that people imagined. That is still working its way through because some of the intervention studies haven't been followed up into adulthood. And we've shown that although there aren't changes in the baby's size at birth from such interventions, there are changes in the baby's epigenome, which we think might lead to lasting benefits, but that's work in progress. So the emphasis has moved to interventions prior to conception, and one of the main driving adverse influences, which is increasingly prevalent in both low middle income countries and high income countries, is maternal obesity. And to be honest, you really can't shift the consequences of maternal obesity if you intervene in pregnancy. And likewise for other adverse influences such as maternal smoking, you can have some benefits by stopping in pregnancy, but you don't move the dial back to the outcomes associated with non-smoking, and likewise with dietary interventions. So we've progressively looked towards behavioral, nutritional, and other stress reduction activities prior to conception, in the hope that these might have both short and longer term benefits for pregnancy outcome and for the offspring.
Let's come back to that in a minute, but I just want to stay in pregnancy for a moment. You mentioned overweight and obesity, which obviously is an increasing problem over time in most parts of the world, also in young women getting pregnant. A very common guideline that clinicians follow is the Institute of Medicine guideline on gestational weight gain, which to my understanding was initially developed to address low birth weight and low weight gain, but it's very much now applied also for advice to women with high weight gain and overweight. How good is the evidence behind that guideline?
So the Institute of Medicine guidelines are widely used globally, but the research has really moved on from there. And in studies beautifully orchestrated by Vincent Jadot and the team in the Netherlands, it's clearly seen that there is a continuum of risk at both higher weight gains across the spectrum and lower weight gains, and that are a range of both pregnancy and offspring outcomes, particularly childhood obesity, have some relation to the weight gain during pregnancy. The influence of maternal obesity appears to be greater than that of gestational weight gain. And I think the world is moving away from attempting to constrain gestational weight gain as a key goal towards trying to optimize maternal weight prior to conception.
Right, so obviously if you want to change body weight of a woman that is getting pregnant, there is opportunity prior to conception. What evidence do we have today on preconception interventions?
So preconception interventions for maternal weight have to date started rather too late, of course, in extreme circumstances. Bariatric surgery for severe obesity, there is evidence of benefit for pregnancy outcomes. For other interventions relating to the preconception period, there are large-scale intervention studies underway within the Healthy Early Life Trajectories program funded by the Canadian Institute for Health Research. And these are complex interventions that include nutritional, stress, other lifestyle activities as a complex bundle in China, India, South Africa, and Canada. Alongside those, there are a few other studies, the WINGS study in Southeast Asia, and our NIPA trial in UK, Singapore, and New Zealand. And these trials are different and have had different outcomes, but they're a sign of what needs to be done going forwards.
What are the key learnings from your NIPA trial?
So in NIPA, we recruited just over 1,700 women who were trying for a pregnancy, and we followed up those women for a year. and among those that became pregnant, just under 600 of them, we've studied the outcomes. One of the key messages from the baseline preconception element was that 90%, 9 in 10, had low or marginal status for key B vitamins, many of which are never measured in preconception or pregnancy period. We intervened with either a standard control folic acid, iodine and iron supplement, or with a supplement containing amounts of B vitamins, vitamin D, minoxidil and probiotics, all of which are purchasable in the sort of quantities we used over the counter. And what we found was that the primary outcome of the study, which was the mother's blood sugar level 28 weeks of pregnancy, was not changed by the intervention, but we did find major shifts in some of the pre-specified secondary outcomes. So key amongst those was more than halving of the risk of preterm delivery, and particularly the main biological category of preterm delivery, which is preterm, pre-labour, rupture of membranes, PPROM, together with a reduction in major postpartum hemorrhage, which, if you think about the major causes of poor pregnancy outcome globally, if it's substantiated, is an important outcome. We followed up the children to age 2 years of age, and although the babies in the control and intervention groups were of similar size at birth, postnatal weight gain, even though the supplementation stopped at birth, was substantially lower in the intervention group, such that the rate of obesity at age 2 years was halved in the intervention group. There were also associated changes in breast milk vitamin D, which may be of immense benefit for the offspring.
That's very impressive results. Halving the rate of preterm birth, halving the rate of obesity in early childhood is really a big benefit for health. If that can be sustained, that's amazing. Now you mentioned the nutrient supply preconception. All the nutrient recommendations around the world for pregnancy indicate that the need for certain micronutrients increases markedly. And to meet that in pregnancy is often difficult. If I just think of some organizations recommending an iron intake of 30 milligrams per day in pregnancy, it's very difficult to achieve and can be associated with non-compliance due to adverse effects. So would it be an alternative strategy to try to build nutrient stores already before pregnancy so that you don't have to give such high amounts during pregnancy?
So for some nutrients that are stored in the body, there is scope for a preferential increase prior to conception, so B12, vitamin D, iron. We actually found that by measuring the stores of these micronutrients longitudinally, that it actually took many months to replenish vitamin B12 stores, for example. And I think realistically, we're looking at commencing preconception, but continuing during pregnancy. And that's particularly the case for the water-soluble vitamins, where they're not stored in any substantial way in the body. And what we found was actually evidence that the levels of vitamins like riboflavin, vitamin B2, were well below the thresholds for insufficiency that have been shown in other studies. So we think that there's a need to reevaluate the existing recommendations and that for some of the vitamins, the recommendations are frankly too low.
Well, thank you so much, Keith, for sharing these important insights, and good luck with the next steps of your exciting work that could really have a major impact for the health of women and children. I really enjoyed the conversation. So thank you all for listening in, and we hope you learned something that is valuable to us. I hope you enjoyed this episode. If you want to listen to more episodes, don't forget to subscribe to the NNI 365 app or the NNI website. Thank you again.
Thank you.
And that concludes today's episode. Thank you for joining us for this special episode from NNI and WNSC Workshop 102. We hope you enjoyed and learned from this quick discussion, fellow experts. Till the next episode.